The topic of lecture is Anatomy and Function of Oral Cavity Organs. Lecturer Dr. Mariana Levkev. This lecture outline anatomy of oral soft tissues in normal limits, anatomy of teeth, histology of tissues, functions of teeth. Introduction to this topic. A good knowledge of normal anatomy and common variations of normal is essential to determine if a structure is within normal limits or abnormal. It is also worthwhile to use the correct terms when referring to different regions of the oral soft tissues to facilitate communication with other dental professionals. General understanding of the patient's oral health status often has a great impact on decision making regarding the possible treatment of the acute problem. Knowledge of normal anatomy of oral cavity structures is important in decision-making process and will provide clues to the likely diagnosis. Soft tissues of oral cavity. It is important to record if the soft tissue is within normal limits or not. If there is an abnormality, further details are noted, such as type of abnormality, size, color, location, surface texture, and consistency. The first step that should be denoted is symmetry and profile. The symmetry of the face is the correspondence of the left side of the face to the right side of the face. Increased development of lagging one of the parts, a symptom of existing dental pathology, or a risk factor for its development. Assess the symmetry of the face as well as the head and neck region. This can be done if the patient is sat upright in the dental chair. Most of us have some types of asymmetries, but significant asymmetries on comparison of one side to the other should be noted. This asymmetry may be bony, soft tissue in nature. It may be acute or chronic, or it may be secondary to previous surgery, for example, tumor resection or cerebrovascular accident. It may have occurred following injury, such as a fall, and the patient presents to the dentist with dearranged occlusion and facial asymmetry due to a mandibular fracture. Dentists should pay attention to the nasolabial and chin fold. They can be smoothed or increasingly visible. The reduction of the lower third of the face is associated with a decrease in the height of the bite due to its pathology, for example, deep bite or abrasion or tooth loss. Enlargement of the lower third of the face is connected with an open bite. The next area which attention should be paid is a cutaneous area. The patient's exposed skin should be examined. Check for any skin lesions, scars, or fistulas. Healthy skin is smooth, elastic, is not dry or flaky, rasping folder. If petechia, ecchymosis, or hematoma are seen, then further information should be obtained from the patient about bleeding problems or medications such as blood thinners take. If the patient's skin appears yellowish, more information is needed about possible jaundice or liver problems. Clubbing of the fingers may be a sign of heart or respiratory problems. On these pictures, just as an example, you can see the cutaneous lesion of discoid lupus and erythema of the face due to the lupus erythematosus. The next, what should be observed is eyes. So observe the eyes for any abnormalities. Yellow sclera is associated with jaundice and may indicate an undiagnosed case of hepatitis A or B, other liver dysfunction, or a blood disorder. Lips. Labial mucosa with the mouth 3/4 closed. Gently grasp the lower lip between the thumb and the first finger of each hand and invert the lip. Record any abnormalities, the labial mucosa such as polyps, scars, ulcers. Scars inside the lower lip are seen frequently as a result of trauma as a child. On this picture is visible the digital palpation of the upper and lower lips that is done by the doctor dentist. Pay attention to the anatomy of the lips. Note small melanotic macule on the vermilion border of the left upper lip near the border, as well as physiologic pigmentation of upper lip. Vermilion border. Look for even coloring, symmetry, and sharp demarcation between the skin and the lip vermilion. Blurring of the edge of the vermilion can be seen in actinic cheilitis, some damage of the lip. Record if there are any abnormalities such as hyperkeratosis, white patches, ulcers, or pigmentation. Check the corners of the mouth. Lip commissures where redness and small fissures may indicate angular cheilitis. Lips frenulum. Its attachment of the lips to the gum mucosa, and there is maxilla and mandibular frenulum. Vestibule of the oral cavity. Maxillary labial vestibule showing frenulum, and mandibular labial vestibule showing as well frenulum by this arrow. In healthy individuals, the labial mucosa is smooth, soft, and well lubricated by the minor salivary glands. And the definition of the vestibule of the oral cavity. So this is the region between the lips and the cheeks and the teeth. The fold of tissue created by vestibule between the lip and teeth is called the vestibular or mucolabial or mucobuccal fold. Here it is, and here it is, mucobuccal fold. Occlusion. Occlusion is defined as the way the teeth meet when the lower jaw and upper jaw come together. It is how the teeth contact in any type of functional relationship. Physiological occlusion is desirable as it allows oral functions to operate properly, provides the best aesthetics, and is helpful in the prevention of disease. Anytime normal occlusion does not occur in the mouth, it is termed malocclusion. Malocclusion can have an effect on dental diseases, chewing, speech, and aesthetics, especially facial profile, and other functions of the oral cavity. Malocclusion can occur for a variety of reasons, and these include, but are not limited to, heredity, trauma, diseases, and habits, such as some sucking. Types of occlusion can be categorized in physiological and pathological. Physiological are subdivided in orthognathic bite, straight bite, physiological progeny and prognathy, and pathological types of bites are subdivided on open bite, deep bite, cross bite. Separately can be outlined mesial and distal bite. Occlusion is examined when dental arches is closed. There are physiological occlusion and such condition when person can normally bite, eat, and articulate, and pathological occlusion that do harm to patients feeding and articulating. Occlusion is checked by asking patient to swallow saliva, and after that the dentist should avert lips. Dental arches should be closed. And on this picture you can see the way of how to determine occlusion. So the patient should be asked to swallow saliva for the first, and then with closed jawbone, closed teeth, the patient should open lips. Gingiva. The normal gingiva is coral pink and firm. The gingiva adherent to the tooth is called the marginal gingiva. It is continuous with the attached gingiva that covers the alveolar process. The attached gingiva is red, smooth, and shiny, firmly connected with alveolar bone. So here you have the anatomy of gingiva: marginal, attached, and macrobuccal fold can be seen over here. On this picture is shown the process of bidigital palpation of attached gingiva and macrolabial fold. Please note color, tone, texture, architecture, and macrogingival relationships. How to determine diseased gingiva? On these pictures, you can see hypertrophic gingivitis, inflammation of gums, and drug reactions to the gum mucosa in those patients who take anti-epileptic drugs, calcium channel blockers, and immunosuppressant. Soft tissues. It is necessary to check the openings of salivary ducts while expressing saliva by gentle pressure. And this is called Stenson duct, orifice of parotid salivary gland. Please check that saliva flows freely and equally from all glands and is clear in color, and do not mistake anatomical variations for disease. Yes, so linea alba that is depicted over here, it is anatomical structure of the buccal mucosa, and possibly by mistake could be diagnosed as let's say leukoplakia. So dental practitioners should be aware of anatomical structures to prevent misdiagnosing. Examination of the buccal mucosa is most easily accomplished by having the patient partially open the mouth, followed by stretching of the buccal mucosa with a mouth mirror. Linea alba on the buccal mucosa actually come very close on the same anatomical place where projection of Stenson duct. Buccal mucosa. In the healthy individuals should be smooth, salmon pink, without any pathological lesions on it. But in the case of any of the disease, there can be presence of some white, red lesions, as it is seen on these pictures. Check, please. Cheek on the lichen planus, lichen planus on the cheek mucosa and on the tongue, and here the same white lesions, hyperkeratotic lesions on buccal mucosa. The hard palate is keratinized and covered by a series of fibrous ridges or rouge. The mucosa overlays a number of minor salivary glands. The hard palate, similar to the attached gingiva, normally is less pink than other oral mucosal sites because of its increased keratinization. And there you can see minor salivary glands, attached gingiva, and note presence of tori. So this is a problem if such patient will have any prosthetic treatment. On the hard palate, please note junction of hard and soft palate. On the dotted line, maxillary tuberosities, thick solid arrows, palatine fovea, thin solid arrows, and rouge, broken arrows over here. And incisive papilla over here is depicted by asterisk. The midline ruff is clearly evident. Soft palate. In contrast to the hard palate, the soft palate is non-keratinized and salmon pink in color. It is easily visible on direct examination by depressing the posterior tongue with a tongue blade and instructing the patient to say "ah." Deviation of the soft palate to one side or other may indicate a neurologic problem or some type of neoplasm occurrence. The tonsillar crypts are highly vascular and appear more erythematous than the surrounding tissues. Patients often have accumulations of desquamated epithelial cells, food, and other debris spread in the tonsillar crypts, which can lead to a scratchy sensation in the throat and halitosis. bad smell from the mouth. Accessory lymphoid tissue on the posterior oral pharynx, so-called adenoids, is normal and appears as pale, irregular mucosal papules. These tissues may enlarge in the presence of inflammation or infection. Tongue. Alternatively, the tip of the tongue can be grasped by the fingers, and fingers should be covered with a gauze sponge. The dorsal surface of the tongue should be uniformly covered by numerous hair-like filiform papilla, shown over here. Interspersed among the filiform papilla are dozens of mushroom-shaped fungiform papilla, each of which contains one or more taste buds. And on this picture, you can see how the dorsal surface of the tongue is most easily visualized by having the patient protrude the tongue and attempt to touch the tip of the chin. It is very important to be able to notice any signs of disease on the tongue. So you may observe lingual varicosities in the case of cardiovascular disease. You may observe geographic tongue in the case of erythema migrans. You may observe drug reaction to the tongue on the lateral surface of the tongue. And please be aware that some nutritional deficiencies and immune dysfunction as well would be observed in the tongue. On this picture, you can see atrophic glossitis in a patient with pernicious anemia. Here you can see mucosal atrophy that appears as a smooth, bald areas without papilla. And on this tongue, a small quantity of Candida fungus is naturally present in the mouth and digestive tract of the most individuals, and it does not usually cause an infection and other resultant symptoms. However, changes in the oral environment under certain circumstances can cause fungus to multiply, causing disease. And here you can see candidiasis that is visible on the tongue. As well, one can observe oral cancer. Oral cavity cancer accounts approximately 3% of all cancers of the in the distribution of cancers. Both the ventral lateral surface of the tongue and the floor of the mouth are common sites for intraoral squamous cell carcinoma. For this reason, the index of suspicion for soft tissue lesions should be heightened, including otherwise innocent appearing red or white lesions. Unless convincing history and compelling clinical evidence, biopsies should always be obtained from chronic alterations and obvious masses to rule out the malignancy. And pay attention to this lateral surface of the tongue as visualization of cancer lesion and lateral border of the tongue closer to the pharynx as well. Malignancy is present on the lateral border. Floor of mouth. Please note frenulum, submandibular duct orifices, prominence of sublingual gland under the mucosa. So it is visible under the mucosa. Floor of the oral cavity should be examined thoroughly and palpated bimanually to check for any abnormalities. Lateral border of the tongue and floor of the oral cavity are the favorite areas for development of oral cancer, and it should be kept in mind. Lingual frenulum is visible over here. It is the primary soft tissue attachment of the tongue to the floor of the mouth. Over-attachment of the frenulum may result in speech impediments, so-called tongue tied. The orifice of the Wharton duct, which are located at the base of the lingual frenulum, appear as a two-bilateral punctate structures. Mucous saliva can be expressed from the ducts with bimanual palpation of the submandibular glands. The floor of the mouth is examined using direct vision and mouth mirrors. As well, it should be examined by palpation. The process is as follows. Place one index finger of one hand in the floor of the mouth, lingual to the molars, and place the index finger of your other hand on the skin medial to the patient's mandible, inferior to your intraoral index finger. Using a gentle up and down motion, palpate the submandibular gland and move your fingers forward to palpate the sublingual gland and floor of the mouth. This examination should not be painful, but it is slightly odd feeling, so the patient should always be informed before starting this examination. Floor of the mouth. On this picture is depicted pathological condition, squamous cell carcinoma. Oral squamous cell carcinoma is a 13th commonest cancer worldwide. It is very important to visualize all areas of oral cavity. There are several types of oral mucosal lesions that may cause pain and which may be difficult to differentiate from odontogenic pain. For this and other reasons, oral soft tissues must be carefully investigated in all patients complaining of some kind of discomfort in the oral region. Investigation is carried out in a good light by direct visual observation and with a mouth mirror. Tenderness to palpation of the mucosa and other oral soft tissues is also investigated gently using the fingertips. Ulcers and herpes are frequent causes of oral pain and may not always be easily identified and located. Wounds and lesions caused by dental procedures and materials such as monomeric resins, mechanical trauma, and allergic reactions are also typical causes of oral pain. Although infrequent, primary or secondary lesions of several diseases of the oral cavity and other regions of the body may be found in the oral cavity. Biopsy and consultation with oral surgeons and pathologists must be done in all cases where there may be uncertainty as to the etiology and type of the findings. Examination of teeth. Examination of teeth should be the final part of the oral examination. Clinical examination of the patient's teeth begins with a general assessment of the health status of the dentition. Points of interest include number of missing teeth, number and size of fillings and other restorations, hygiene conditions such as plaque and gingival bleeding, and occlusion. Here you have tips for dental examination. Any number of developmental defects of the teeth may be apparent. Partial anodontia is a common occurrence, especially involving the maxillary lateral incisors. Supernumerary teeth, for example, mesiodens, also are commonly noted. Missing teeth and supernumerary teeth are commonly found in a variety of inherited disorders, for example, Gardner syndrome, orofacial digital syndrome, etc. Gross decay of the occlusal biting surfaces of the teeth usually appears as discolored cavitations and represents the sequela of poor oral hygiene. Decay involving the interproximal, for example, tooth-to-tooth contact surfaces, may not be clinically apparent without the aid of dental radiographs. The decay at the gingival margins of the teeth adjacent to the attached gingiva may be the first manifestation of xerostomia. Root surface caries are also commonly observed in geriatric patients with gingival recession. As a minimum, the standing teeth with a summary of their periodontal health, caries, and restorative status should be recorded. Tooth wear should be checked for parafunction. Dental examination should be thorough, both for the patient's sake and for medio-legal reasons. When dental pain is a possibility, full charting, assessment of mobility, and percussion of teeth are necessary, and further dental investigations will probably be required. Numbering systems that can be useful if it goes about tooth notation. So the knowledge of how to denote teeth is essential in dental assistant. So we have few standard numbering systems that are used in dentistry. Universal National System, it was developed in 1968, and most commonly this is used in the United States. Federation Dentaire International System, Canada and European countries use this notation system. It is easily adapted by computer and is widely used in most countries. Palmer system uses a different bracket shape for each quadrant as indicated, whereas the international system uses the numbers 1 through 4 to denote each adult quadrant. And now in detail about tooth notation using different numbering systems. Universal National Numbering and Lettering System. As you can see, here we have the oral cavity, maxilla and mandible jawbone, and teeth positioned in the arches. Oral cavity is subdivided on the 4 quadrants. So here we have 1, 2, 3, 4. But in this universal numbering system, there is a tooth calculation from last molar, third molar, moving through the dentition, and in such way, in maxillary, we have 16 tooths, and then we proceed to the mandible, starting from the 17, it would be the last molar of the mandibular left, and proceed through all dentition to the mandibular right, and this ends with 32 number. For temporary teeth, for primary teeth, similar principle, but instead of numbers, letters are used. Starting from the last molar of the maxillary right, from the letter A, moving through the all jawbone to the letter G, and then proceed through the mandible teeth and finish in the last in the premolar of the mandible. Federation Dentaire International, or FDI, numbering system. Oral cavity is divided in 4 quadrants. To each quadrant is assigned number 1, 2, 3, and 4. And then for every tooth there is as well number, starting from the central incisor of the one part of the dental arch. So we have central incisor number 1, lateral incisor number 2, canine number 3, premolar first 4, premolar second 5, first molar 6, second molar 7, and third molar 8. So the same principle for all teeth in the all dental arches, maxillary and mandibular. To denote the tooth of a certain quadrant, it is necessary to put the first number of the quadrant and second number of the tooth. For example, we need to denote canine of the maxillary right. So we should put 1 as the first number of the quadrant and 3 as the number of the tooth. So we have 1, 3. This is a number of the maxillary right canine. Similar for the mandibular canine, number 3 is a number of the quadrant and 3 number of the canine tooth. So we have 3, 3. This is a number of the mandibular left canine. Similar principle of tooth notation for primary teeth, and quadrants are numbered 5, 6, 7, 8, yes, and the same principle 53, 63, 73, 83, yes. Palmer system for numbering of teeth. Instead of writing number of a quadrant, here we use such brackets, yes, and put here in this bracket the number of the tooths that should be denoted. For example, central incisor 1, lateral incisor 2, and the same over here. The brackets are turned in such a way, they are bent, angled in such a way as a dental arch looks like. The same for primary teeth, but instead of numbers, letters are used. And we proceed with the next chapter of this lecture, teeth anatomy and histology. Anatomical and histological features of the teeth. In adult humans, there are 32 permanent teeth. They are preceded during childhood by 20 deciduous teeth. The tooth lies in a bony socket. The alveolus that is covered and oral mucosa called the gingiva, excuse me, Here you have the names of the teeth. Excuse me for a minute, please. So we have such groups of teeth: incisors, canines, group of premolars, and group of molars. Tooth structure. Tooth tissues comprise enamel, dentine, cementum of the root that covers dentine of the root, and pulp tissue. Separately, we should outline periodontal tissues that consist of periodontal ligament, cementum of the root, alveolar bone, and gums. During follicle stage of tooth development, it moves through certain stages, such as the bud stage, cup stage, bell stage, and apposition and calcification. All this process starts from the 8 weeks of intrauterine life, proceeding till 14 weeks of intrauterine life. Characterization of enamel. Enamel is a highly mineralized tissue in the human body, and this is the hardest tissue. Enamel covers anatomical crown of the tooth and varies in thickness. It is semi-translucent, and the color can vary from bluish-white to hues of yellow. Chemical composition of enamel. Enamel consists of 96–97% of inorganic material by weight. The main inorganic component being hydroxyapatite, 1% organic material by weight, the main organic component being protein, and 2–3% of water. Enamel is made up of millions of enamel prisms or rods, which run from the amelodentinal junction to the enamel surface. And each prism is made up of a large number of enamel crystallities. Dentine is a mineralized tissue forming the bulk of the tooth. It underlies the enamel in the crown area and is covered by cementum in the root area. Dentine is pale yellow in color and is harder than bone and cementum, but not as hard as enamel. Dentine consists of 70% inorganic material, of which the main inorganic component is hydroxyapatite. Organic material constitutes 20% by weight. The main organic component is collagen fibers that is embedded in amorphous ground substance. The remaining 10% by weight is water. Dentine consists of many dentinal tubules that run parallel to each other, following a double-curved course and extend from the pulp to the amelodentinal junction. Each dentinal tubule contains an odontoblast processes surrounded by intercellular ground substance composed of fine collagenous fibrils. The odontoblast cells are a layer of closely arranged cells on the pulpal surface of the dentine, with their nucleus situated at the basal pulp pulpal end of each cell. Age changes in dentine. Dentine is a is a living tissue, and with age, more dentine continues to form slowly. This dentine is termed secondary dentine. Secondary dentine is laid down at the pulpal end of the primary dentine. As a result of this, the pulp chamber reduces in size with age. Peritubular dentine tends to increase with age, reducing the diameter of the dentinal tubules. The tubules may also become completely obliterated, and when this happens, the dentine becomes more translucent, and this is termed translucent or sclerotic dentine. Reparative dentine or irregular secondary dentine is laid down on the pulpal surface of the dentine in response to an external stimulus, for example, caries, cavity preparation, or excessive tooth wear. Following a severe stimulus, the odontoblast process may be destroyed and the contents of the tubule then necrose, leaving the dentinal tubule empty, and this is termed a dead tract. Cementum is a pale, yellow, calcified tissue that covers the root dentine. It can be easily worn away, resulting in exposure of the dentine. Its thickness varies according to location. It is thickest towards the apical third of the root and thinnest cervically. Cementum is 65% by weight inorganic, mainly hydroxyapatite, 23% organic, mainly collagen, and 12% of water. Certain features are typical and significant for cementum. It can be distinguished cemento-enamel junction, due to age, some functional changes of cementum can develop. There can be resorption, hypercementosis, ankylosis, and concrescence. Cementum performs two essential functions. First, it provides the attachment to the tooth, to the alveolar bone by insertion of principal fibers of periodontal ligament, and second, to prevent root resorption during remodeling of the periodontium. Dental pulp. So this is a soft vascular connective tissue that occupies the center of the tooth. The shape of the pulp approximately follows the shape of the outer surface of the tooth. The pulp is made up of a pulp chamber in the crown and root canals in the root area. The shape and number of root canals can vary considerably. At the apex of each root is a foramen through which blood vessels and nerves enter the pulp chamber. Small projections of the root canals are found under each cusp. These are called root canal orifices. Shape and form of the pulp tissue can be easily visualized on the X-ray. Pay attention to this X-ray translucency. This is pulp chambers, and this is pulp horns that can be found under each cusps. Dental pulp has several important functions to maintain tooth integrity. They are protective function. It mobilizes defense cells when bacteria enter it. Dentinogenic function, such as it maintains through odontoblasts that are responsible for dentine formation and can generate a process of collagen fiber mineralization from predentine. Sensory function. The pulp responds to injury with pain, and it is one of the most important functions of the pulp as it uh, prevents tooth from being destructed. Nutritive function. It provides nutrients to the odontoblasts. Reparative function. The pulp responds to insults, bacterial, iatrogenic, and traumatic, for example, in restorative techniques with an inflammatory process. And cells proliferating in the pulp tissue create pressure, and this is thought to play a part in tooth eruption. Periodontal ligament, the next structure that should be discussed. This is specialized fibrous connective tissue that surrounds the root area of the tooth. It consists mainly of collagenous fibers, and it has the following functions. It provides a support mechanism for the tooth. It cushions teeth against excessive occlusal forces, preventing damage to the blood vessels and nerves at the root apex. It maintains the functional position of a tooth by keeping the teeth in contact and prevents the tooth from drifting or tilting. The periodontal fibers undergo continuous change. Its cells form, maintain, and repair the alveolar bone and cementum through the lifetime. It acts as a sensor in the periodontal ligament and provide proprioceptive input, detecting pressures on the tooth and preventing from being cracked. The periodontal ligament has a rich supply of blood, which provides nutrients to the cementoblasts. On this diagram, you can see different types of periodontal fibers that surrounds the root. They are transeptal, dentinogingival, circumferential, alveolar crest, horizontal, interradicular, oblique, apical, alveolo-gingival. The next structure that is of great importance in the dental therapy is periodontium. Periodontium is defined as the supporting tissues of the teeth in the mouth, including surrounding alveolar bone, gingiva, periodontal ligament, and the outer cementum layer of the tooth roots. Saliva and salivary glands. Produced in salivary glands, saliva is 98% water, but it contains many important substances, including electrolytes, mucus, antibacterial compounds, and various enzymes. The digestive functions of saliva include moistening food and helping to create a food bolus so it can be swallowed easily. Saliva contains the enzyme amylase that breaks some starches down into maltose and dextrin. Thus, digestion of food occurs within the mouth even before food reaches the stomach. Secretion of saliva ranges from 500 milliliters up to 2000 milliliters. Saliva contributes to the digestion of food and to the maintenance of oral hygiene. Without normal salivary function, the frequency of dental caries, gum disease, and other oral problems increases significantly. This diagram represents the most important salivary function that maintains health of oral cavity. Remineralization is done due to presence of calcium and phosphate ions in the composition of saliva. Cleansing function is done due to flow rate and daily production of more than 500 milliliters. Buffering capacity due to bicarbonate and phosphate buffers. Lubrication that helps in articulation due to proline-rich glycoprotein mucins. Protective function is maintained by lysozyme, immunoglobulin, histatins, lactoferrins. Digestive or taste function is done due to amylase, proteases, and zinc. And bolus formation is done due to mucins. But what is oral fluid? Oral fluid is the liquid that is present in the oral cavity. Oral fluid is a mixture of saliva and oral mucosal transudate. For opposite, saliva is a pure secretion of salivary glands. Oral mucosal transudate enters the mouth by crossing the buccal mucosa from the capillaries. Oral fluids contain both pathogens and antibodies. It can contain remnants of food as well. Structure of teeth. In a primary teeth. So we have such groups of teeth. Incisors, upper, central, lateral, mandibular, central, lateral, canine, first molar, maxillary, mandibular, second molar, maxillary and mandibular. Permanent teeth has one more group. It is premolar group. So after canine goes first premolar and second premolar, and the rest teeth are the same. Upper central incisor, upper lateral incisor, canine, first premolar, second premolar, first molar, second molar, and third molar. For the dental practitioners, it's essential to be aware of the names of the tooth surfaces. So, in general, we name the teeth for posterior and anterior. Anterior from the canine to canine, posterior, premolar, and molar groups. The surface that is turned to the lips has the name labial in anterior group of teeth and buccal in posterior group of teeth. The surface that is turned to the hard palate or to the tongue in mandibular has the name palatal for maxillary and lingual for mandibular teeth. In posterior group of teeth, masticatory surface has the name occlusal. In anterior group of teeth, it is called incisal edge or cutting edge. Surfaces that are between teeth have the name interproximal surfaces. Every tooth has mesio-proximal and disto-proximal surface. And this can be figured out by providing imaginary line, by crossing the imaginary line between central incisors. And the surface that is close to the imaginary midline will be mesial. Surface that is far from the imaginary line would be distal. Every tooth has its function. Incisor is a tooth that has one root and it is used for cutting of food. Canines has a function to rip the food. Premolars, they are used to grind and to masticate food. And molars, molars' function is crushing, final crushing of the food and mastication of food together with premolars, of course. In conclusion to this lecture, it is important to state that dental assistant is a part of a dental team, and this is of vital importance to have general understanding of the patient's oral health status. Knowledge of normal anatomy of oral cavity structures is important in decision-making process and will provide clues to the likely diagnosis. Because dental assistant is a second pair of eyes to the dentist, they can provide good visualization, support in visualization of oral cavity. And this has a great impact on decision making regarding the possible treatment of the acute problem. References to this lecture: questions for self-control. Thank you for being with me. Have a good day.